In this video, I sit down with Dr. Brad Fullerton of Prolocoaster. Dr. Fullerton is a world-renowned physical medicine and rehab physician specializing in non-surgical ways to heal. Together we talk about how to improve your knees, even if you have knee arthritis. Specifically, what type of injections will further harm your knees versus what type of injections will help your knees heal and repair. Dr. Fullerton, thank you so much for sitting down with me.
You bet.
I'm really excited about talking about all things knee health.
Yes.
I'm curious if you can tell us if you have a new patient come in and they have knee arthritis, what do they typically complain about?
Well, knee pain, right? Most commonly along the inside of the knee and the front of the knee, but sometimes the outside. So, and then usually some swelling if they have decent arthritis going on, stiffness, limited range of motion, right? So all those things. And they tend to focus at the knee, and then I start expanding where they look for what's causing this.
Yes, yes. So where are some of the places that you look?
So, well, I mean, that leads immediately to tensegrity ideas.
Okay, let's jump right into it. This is like my favorite word. Dr. Fullerton publishes it academically and uses it in patient education, but biotensegrity, right?
Biotensegrity.
And this is a biotensegrity model.
Yes, well, this is a tensegrity model.
Tensegrity
So
model.
tensegrity applied to biologic tissue then would be biotensegrity.
So tell us all about what that means.
Okay, so here's what I tell patients when I first meet them, right? We look at bones like this femur, tibia, fibula, and we think that's the frame of the body, right? And so we kind of automatically think that whether we're 5 years old at Halloween, where we see bones, or if we're a PhD in biomechanics, bones are the frame. And we think that way because if we were to build something, we would need it to be stable. And if it's going to be stable, it needs to be hard and solid.
Right.
So that's the frame.
Yes.
So then the things that are attached to the frame would be all the fibrous tissue like ligaments and tendons, the muscles, right? So all of those things would be attached to, and they would be kind of secondary to. So the muscles, for instance, we start learning anatomy and we learn muscles originate on one bone, insert on another bone. And so when those muscles shorten, it pulls one bone closer to another.
Right.
And that's how we move, right?
Yes.
So the muscles are pulling the bones around. And the only problem with that whole construct is it's wrong.
Yeah.
So it's not how we develop, right? We're born as little cells, or we're conceived as little cells, and we're soft. And we're soft for a long time while we develop, right? We don't have any hardness to us. Eventually, hardness starts to form within our bodies, and that's the bones. But it's really hardening of soft tissue. So you get a hardening in a soft tissue structure, and so the structure itself starts soft. And when we think the structure is solid, we're misleading ourselves. What we have are islands of hard things within a soft tissue frame.
Yes, okay.
Right?
Yes.
So that's much closer to what this represents, right? So if you were going to move this structure or get some energy going through it, you wouldn't be pulling on one of these solid things, right?
Right.
All of these solid things are floating separate from each other in a continuous network of tension. So these things are under tension, these are under compression, they're being kind of crushed, pulled together.
Yeah.
These are being pulled apart by these solid things.
Right.
But they're all in balance. And what that does is it creates really almost instantaneous communication through the whole structure, right? So because
pulling here is going to affect up there and down below. And
right. So if I push on one spot here, it's not just compressing this one little spot. It's reverberating through the whole structure, right?
Right.
And it's actually changing the shape of the whole structure.
Yes, yes.
So if we have a fall on our knee, right, 10 years ago, and then that knee begins to develop degenerative arthritis.
Right.
Right? And you have breakdown of bone, the bone's reshaping, cartilage is breaking down. Why is that happening? Right? So for me, if you want to hear old stories, I started having cartilage breakdown in my kneecap in 1992, late in 1992.
Okay.
I was a resident in psychiatry at the time.
Okay.
And I went and saw a world famous knee surgeon at the medical school where I was in Connecticut. And he sent me to rehab for 6 weeks, which didn't help, unfortunately. And Then I went into surgery, and he said, I've got to cut this tissue over here because it's too tight.
Oh, you had the lateral
Well,
release.
I give him credit for not doing the lateral release.
Okay, what did he cut?
So I woke up from the surgery, and he said, oh, I didn't do the lateral release because, you know, your patella was your kneecap was tracking fine when I was moving your knee. But you had cartilage worn down almost to the bone on the superior pole of the patella. So I cleaned that up, which means he tore some tissue out.
Right.
Made it look smooth.
Yeah. Shaved and
then he
trimmed.
said, you know, you can get back to running in 6 weeks. I was in my late 20s. And so I, you know, iced my knee like crazy afterwards, like this big device. And then after that, I couldn't walk without pain. So before the surgery, I was walking without pain, but I'd have pain after running. Now I couldn't walk without pain. So I followed up with him. Like, I'm worse. I'm limping all the time now. Oh, well, we have to do this bigger surgery. We cut under your bone. We push your kneecap to one side, which made no sense because he said the patella was tracking normally.
Yeah.
Right? Plus, his first surgery and prediction was completely wrong.
Yeah.
It didn't work.
Yeah.
So I thought to myself, why would I trust this man again? His first prediction was completely wrong.
Yeah.
Even though he's world famous, he's not looking at me as an individual and trying to understand me, right? So, long story short, that little bad event was a serendipity. It was a gift that I didn't realize, and that led to my career because I started looking for other answers before the internet and social media and all this stuff.
Right.
I had to go to the med school library and try to read, and I tried to call my older brothers who were doctors and get through that whole process of trying to figure out some other approach, which led me to discover physical medicine and rehab as a specialty. And then I went and saw a physical medicine and rehab doctor, and he actually did a full history and exam and got me started in better rehab techniques. And then I started getting better and getting back to where I was before the surgery.
Yes.
But then I was kind of stuck in that holding pattern for years of doing the same repetitive exercises for many years to maintain myself. If I backed off on the same repetitive exercises, then I couldn't ride a bike or my knee would hurt.
Oh, interesting.
Yeah.
Yeah.
So eventually I found prolotherapy, which is the idea of injection to stimulate repair. And I treated my knee, I treated my ankle, which had an old ankle sprain.
Okay.
And then I started getting this pain at my sit bone on the right side of my pelvis. And I was like, I know that pain.
Yeah.
That's where I landed on the mountain bike bar in front of the seat at YMCA of the Rockies about 4 months before my knee pain started.
Oh, interesting.
Yeah. So little did I know I was living biotensegrity. So what had happened is I had come off the seat of a mountain bike that was rented and too tall for me.
Yes.
And the bar was straight across because it was 1992. They really weren't making that. So I came off the seat, landed perfectly on that bone, and I damaged my pelvis on one side.
Okay.
Torqued the sacroiliac joint and damaged the adductor magnus tendon attachment there. And so then I was running for 4 months on my whole right side was torqued, and so that's why my cartilage started wearing down at my patella.
Got it. Yeah.
So the problem wasn't my knee. That's where the problem was presenting, but it wasn't where the original problem was. But that was way beyond what that surgeon was thinking.
Sure.
I mean, he was a knee surgeon.
Probably
All he
didn't
does
have...
is look at the knee.
Yeah.
Kind of sad.
Yeah.
But I mean, he's a great surgeon. He has great information, but if you don't apply that to the individual patient in the office, then
it's problematic.
It's problematic.
Yeah. So when someone comes to see you, you've heard, okay, this is where the complaint is. Let's say it's the knee or whatnot. This is where the complaint is. This is how it's limiting their life. And this is what they want to get back to. Once you kind of understand all of that, what do you do next to determine like the best non-surgical approach for that person?
So most things, most of these instances of degenerative arthritis causing knee pain, or being part of the cause of knee pain, they get referred to a process of control the inflammation and then operate. And those are kind of the two things. In between, they may be referred to someone like you and work on
cartilage strength
and muscle conditioning and neuromuscular pattern right? Getting muscles to work together better,
thickening
and all
that fluid inside their knee, all those good things.
So they may or may not be referred for that, right? And if they are
Most
referred,
often
will
not,
it be as detailed as it needs to be
Exactly.
to get the results you need? Like my first PT thing didn't work, but they weren't doing quite the right thing.
Right.
So it's hard. It's complicated.
Yeah.
I'm going to do a lecture to start a conference in a couple of months, and the opening lecture is called "It's Complicated." Because the soft tissue is complicated, and we don't understand it. Right? We're trying, but we don't understand it. So some of the most common things that I work on. Well, you asked how to decide.
Yeah.
I do some different exam techniques to look at what's inhibiting muscle. So if there's a loss of tension somewhere in the system from an old injury,
right?
If we can put the tension back into the system in the right spot, they may be able to instantly do something they thought they couldn't do. So if they're sitting on a table straightening their knee and they're going, oh, that hurts when I do that, I may find a spot in their quadriceps, the front of the thigh muscles, that has been injured in the past. Put a little tension, support in the right spot, and then suddenly they go, oh, I can extend my knee and it doesn't hurt. Why is that?
Yeah.
So that's because the bones are floating in a little different way because we've changed the tension and the muscle, the ability of the muscle to turn on at the right time.
Yes.
Right?
Yes.
So for me, I treat the quadriceps a lot in people who have knee pain.
Sure.
There are lots of old quadriceps injuries. And if a physical therapist who understands it is trying to strengthen things and they're swimming upstream, right? It's like we can maintain, but we can't get them to where we need them to be. Oh, they had that old fall 10 years ago where they landed hard on their knee and, it was fine after that. So they healed. They adapted, right? So where's the adaptation that's throwing things off that we need to either loosen something that's too tight or tighten something that's too loose, right? So that's where we want to stimulate repair, which is the whole idea of prolotherapy originally is proliferation. You're trying to proliferate normal tissue. So it's injection to stimulate repair, whereas the tradition is injection to block inflammation.
Yes.
Right?
Yes.
Inflammation is also how you repair.
It's a good thing.
And so,
in the right amount.
Yes, in the right amount, at the right time.
Yes.
And with the right resolution of that inflammatory process.
Yes.
Right? So if you sprain your ankle and it swells up, well, it's swelling for a reason. Right? Your body's going to start repairing. What we're taught to is immediately try to stop the process.
Yeah.
Ice it, take anti-inflammatories, stop the inflammation. It's like, no, you want that inflammation at the beginning of the process to get a repair process going.
The body's wisdom.
Right.
Yeah.
Right.
Yeah.
So with regenerative injection therapy, prolotherapy, we're trying to start that normal inflammatory process so that it will progress through repair and then resolve itself. Right. Rather than just block the inflammation.
Yeah.
Right.
And what time frame do you give people? And does that depend on what you're injecting? Tendon versus ligament versus the joint itself?
Yeah, and what substance to inject, right? So maybe this is a good place to explain different injections.
Yes.
Okay, so the traditional things are corticosteroids, right? There's steroids to block inflammation.
And those are the anti-inflammatory bombs.
Anti-inflammatories. I use them very occasionally. There are times they're justified, but they're way overused, in my opinion.
Right. I would agree with you.
Yeah, and there's plenty of studies showing if you inject them repetitively over time, they actually break down the cartilage more.
Yes.
So they can be used sparingly, but I almost never use them in the knee. Almost.
Yeah.
So, but those are the most common things.
Sure.
So I try
27% of people that go to see their orthopedist get steroid injections in the first visit.
Right.
The first visit, they're told they have knee arthritis, and boom, they go directly to that.
And a lot of times people say, I didn't really want it, but it just, and I totally identify with that. I was sitting there in that surgeon's office. I was an MD at the time, right? I had my medical degree, but I was very young, right? Early, and was just out of medical school. And he told me something so confidently, and he's world famous.
Yeah.
I was like, of course he knows what he's talking about. You learn the hard way that they don't always know what they're talking about. They're just confident. And they have a lot of knowledge, but they may not be applying it to you specifically in the way it should be applied.
Right.
So anyway, so the corticosteroid's the thing, and if someone immediately says, "Oh, get a steroid and I'm going to inject your knee," you don't have to do it. You can say, "Hold on, I don't want an injection today. I want to talk about it and think about it."
Yeah.
That is fine.
That's a great
If the physician is offended by that, then probably you need to see a different physician because they're not respecting your autonomy, right?
100%.
Yeah. Okay. So keep that in mind. And then the next most common thing now is hyaluronic acid, or HA. Some people refer to it as rooster combs injections.
Or gel injections.
Gel injections. The rooster combs was the first place they kind of got that from.
Okay.
It's basically a lubricant in the body that's all through the body in all these different tissues. And it helps things glide and slide and maintains the health of the joint. And those can be good. There's controversy about whether they really help or not. And there's big studies showing yes, they do. And some say no, they don't really help overall. But most insurance still covers them. I think overall they are helpful, and they're certainly not harmful like the corticosteroids.
Yeah, agree.
And then we often use those in combination with the things that I'm more used to doing, which would be the prolotherapy injections, which are most traditionally are dextrose, sugar, usually about a 15%, and which is more concentrated than what's in your bloodstream. And so it's a little irritating to the body to have a high level of sugar in a tissue where it's not used to it. And so your body's going to have to respond in some way. And there's ideas of how it responds and how it affects inflammation of nerves. It actually calms inflammation of nerves, the sugar. And then it also, we think, stimulates some repair process because your body has to get more blood flow to the area to kind of clear that out.
Sure.
Right? So that you have to do repetitively. Most people need at least 3 or 4. But you're not just treating the inside of the joint, you're treating all the soft tissue around the joint that could be affected. So the tradition of prolo is to actually inject broadly in these soft tissues around the knee to get some repair in all those rather than just the cartilage itself, right?
Do you include the cartilage itself and the surrounding?
Well, not injecting into the cartilage, but inside the knee so that it kind of bathes the really what you're treating is the synovial lining, the lining of the joint. You're trying to improve the health of that.
Right.
So, and then the cartilage is going to do better if the synovium's doing better.
Sure.
Right. So,
because that synovium is producing that thick, healthy joint fluid in an ideal situation.
And in unhealthy joint fluid, there are actually abnormal inflammatory signals that can break down cartilage. So inflammation can be a maladaptive thing that goes on for a long time that actually contributes to the breakdown, decline of health. So there's it's complicated, right?
Yeah.
we talked about that. So there are times you want to calm inflammation down, but it's not necessarily through corticosteroids. You can calm it down with sugar, which is very counterintuitive. For instance, there are studies showing if you get a pepper, the pepper kind of stuff that makes your lip burn when you eat a pepper, right?
Yeah.
Capsaicin.
Okay.
And you apply that to the lip in a strong, so your lip really burns.
Right.
And you take a little ointment, one with sugar in it, one without, and spread it on either side, not knowing which is which. And then you rate the pain on your lip every minute for 10 minutes on each side.
Okay. The
sugar side drops rapidly. The other one drops more gradually and slowly over time.
Oh, interesting.
Yeah. So there's something about sugar that there's theories about what's called TRPV1 channels that have to do with neurogenic inflammation caused by irritated nerves.
Okay.
And that process, again, resolves quickly because your body gets rid of that pepper, right?
Yeah.
It absorbs it and processes it and gets rid of it. But for some reason, the nerve irritation calms more quickly if there's sugar around.
Fascinating.
So if you eat a pepper and your mouth's burning, drink some milk.
Right.
Right. Well, that milk has sugar in it.
Milk. Yeah.
You could drink lemonade, swish it around. It'll calm the burning down.
All right. Okay.
It's strange. Now, the acid in the lemon may irritate things a little, right?
Yeah, a little give and take.
Right. Give and take. So we think that's why dextrose prolo was found decades and decades ago. This is something that's not particularly irritating, actually calms neurogenic inflammation a little bit, and also stimulates a little repair. But it's kind of gentle. So you need to do it like every 4 weeks or so, do 3 or 4 treatments. I did that for years. without ultrasound imaging or anything. You press where people are tender along the end. Like if you're pushing on a knee joint, a lot of people are very tender right along here.
Okay.
Right? The inside of the knee, where the meniscus is, this is the medial collateral ligament. You're pressing all along like this, and oh, that's really tender right there, right there.
Yeah.
So there are little ligaments that attach this meniscus to that bone.
Exactly.
And one of the earliest changes in degenerative arthritis is breakdown in the meniscus. Right? And I think that's because these ligaments are gradually loosening as we age and from old injury. The meniscus then is sliding around too much, and it's getting weird pressures through it, and then it starts to fissure and break down. And so 30, 40 years ago, 50 years ago, physicians were going, oh, you're tender right there. Something wrong with the tissue. You shouldn't be tender. Inject a little dextrose. Oh, hit there. Oh, inject dextrose there. Oh, you're tender there. Inject dextrose. And they would just go every place you're tender. And oh, you're tender up here. You're tender up here. Oh, let's go out here. Oh, you're tender there. Inject some dextrose. Inject some there and there. And then physicians who weren't understanding the technique would look at that and go, well, you're crazy. You don't even know what you're treating. You're injecting all over the knee. You don't know what you're treating. It's like we're treating a network of fibers that are breaking down, right? It's impossible to injure just an ACL.
Yeah.
Right?
Absolutely.
Yeah, you injure all kinds of other tissues. I've had people with meniscal tears that were asymptomatic if I supported the quad that gave way before the meniscus tore. You support the quad, and then they go, oh, I don't feel that slippage right there. So the way we move is just so simplistic when we think muscles pull on bones.
Right.
It's just much more complicated than that.
Yes.
So the next most common thing that people use to inject is your own platelets, right?
Yes.
So that's the platelet-rich plasma, or PRP, right? So you draw blood, spin it in a centrifuge, most commonly 2 different spins so you can concentrate the platelets well. And then the most common way of using that, and that has been studies, is injecting it inside the joint. Just one injection, getting inside the joint, let it spread all through the cartilage. And that's been shown to be effective. To me, it should be covered by insurance now. There's really good evidence for it. It's not covered by insurance. Eventually, we'll see. But again, it's against that idea of anti-inflammation is the key to every pain. Which is not true. So the key to those injections are you need to inject enough of the platelets. The total number of platelets needs to be high enough to get a response.
Okay.
So there's a lot of what people call platelet-rich plasma that may be 2 times the concentration of what's in your bloodstream of these platelets. And they draw 10 milliliters, like 2 teaspoons of blood, spin it a little bit, concentrate by about half, inject that, and they call it PRP. It's not.
What do you use?
Minimally, so it's usually 6-7 times the concentration.
Yeah. Okay.
I'm usually drawing 60 mLs instead of 10 or 20 and concentrating, and then using most of that platelets that we get from the 60 ml inside the joint to get enough platelets inside the joint. But the rest, excuse me, I'm using at other places where there's soft tissue problems that I've found through exam, history, ultrasound imaging. And so I'm often treating all these spots around the knee I was pointing out with the dextrose, but also up in the quadriceps or in the thigh. On the outside of the thigh, there's a real important structure that I present a lot in meetings.
Okay.
Which, if you're interested, is the lateral intermuscular septum of the thigh.
Okay.
And that is one of the most common places I treat, not just in knee pain, but in back pain, hip pain. It's a structure that's fundamental to why we can walk upright, and yet it's looked at as this connective tissue, right? It's really contextual tissue, right? So your quadriceps, your lateral quadriceps on the outside of the thigh, again, if we learn they originate from bone, then we don't learn. The most important thing is that a large portion of it originates from the lateral intermuscular septum.
That's its anchor point.
This connective tissue, soft thing that the muscle is actually originating from, not the bone.
It's pulling on that.
Yeah.
And if that isn't strong.
It's tensioning that.
Yes.
So, and if that tissue is not tensioned by part of your gluteus maximus, your main buttocks muscle, that pulls on that. So if that's not pulling and tensioning that soft tissue, then the quadriceps won't work. And then your knee falls in, right?
Yep.
So you do a squat, your knee falls in, you get knee pain. Then if you tension higher up along the thigh, along this structure, and those two things work together better, suddenly your knee doesn't fall in, and my knee doesn't hurt when I do a squat.
Yeah.
So you know about glute strengthening, right? You
Right.
strengthen glutes all the time to treat knee pain,
Yep.
right? But if you've had a fall in your hip, or you've done repetitive jumping exercises on one leg over, a sport over your lifetime and eventually develop knee pain, that may be breaking down in that soft tissue area. So I need to write an article about this, but I've done a lot of presentations. I still haven't written an article. I need to.
Well, we'll start to spread the word, but
Yes.
yeah. So after someone gets these regenerative medicine, PRP injections, what are your recommendations to them afterwards? Do you have things that you suggest that they do, or things that they should avoid, like pitfalls that undermine the
big things are ballistic stress, so like bouncing hard stress, right? Which they're not going to feel like doing anyway, right? A lot of rotational stresses, like walking on uneven ground, right? Because you're getting that twisting of this unstable structure of the meniscus. So early on, right afterwards, you want to be doing that, which again, most people who are having knee pain for degenerative arthritis are not feeling like doing that stuff anyway.
Yeah.
Right. So we usually say, I like to give general instructions that are simple, right? Okay, so you're going to back off on what you were doing before. Let's say someone was, maybe they were doing a regular workout and doing leg presses and all, despite their knee pain, right? We're going to go, okay, back off on that. Just do normal walking to tolerance, right? Walking around the house, walking as long as it's not irritating the knee for 2 weeks. And then if you feel like, okay, it's feeling okay, then introduce the exercise you were doing before at 10% of what you were doing before. And the key is a lot of people, especially if they're driven athletic, they'll start doing an exercise. They're going, man, this is feeling good. I'm back. And they just do their whole workout.
Yes.
And it's like, you think 10%, if I could do 20 of those before, I'm going to do 2.
So 10% in the intensity and the duration,
Right.
all of those aspects.
Just to test it, right? And you go, okay, that feels fine while I'm doing it. Well, stop, give it a day, and see what your body tells you.
Observe it for 24 to 48 hours.
So then if you're going, that didn't really irritate anything, well, you can go up another 10%, right?
Yeah.
But you just have to be real logical about it, right?
And pretty disciplined.
Pretty disciplined.
Yeah.
Yep. And it's, especially with people who are driven and athletic, and there's opposite folks who kind of don't want to do anything and they need a little more push, right? And we're all different.
Right.
So, and the key then is your body is building new tissue and it's adapting that tissue to stress as it builds, right? So you want a little normal stress through the tissue. So you don't want to just, I'm going to do nothing.
Mobilize it, lay in bed on the couch, right?
I had one guy who did not hear anything I was saying about this, and he laid in bed for 4 days after the PRP because he thought somehow that was going to help his knee heal. Instead, he got a blood clot.
Oh, no.
Yeah. It's the only time I've ever seen that happen, and it was because he wasn't moving.
At all.
Yeah. So it's like you need movement. Even if it hurts a little bit, you get up and move around, right? Keep a little motion through it.
Right.
Do some quad sets, right?
Yes.
Right?
Yes.
So over time, then your body should gradually improve. But what we tell people, we say the prolocoaster is what you'll be riding. So you're up and down. Some days you're going, I think it's better. Oh my gosh, I'm back. And then the next day you wake up going, oh my gosh, it's as bad as ever. I've fooled myself.
This didn't work. Yeah.
Didn't work.
Yeah.
I need to go get a steroid shot.
Right.
No. Deep breath. Hold on.
Hang in there.
You're riding the prolocoaster a little bit. Just kind of ride the ups and downs. And then usually, if we use platelets, for instance, I'll do one big treatment. And then I wait at least 2 months. You really don't know what tissue you're going to get for 6 to 8 weeks. That's when things are tightening. That new tissue is tightening down and getting stronger. And then your muscles have to learn how to interact with that tissue. And so really I like to wait closer to 3 months before thinking about a second treatment with platelets. So, and I've had one of your mentors, for instance, who wanted to experiment and say, how long is this repair going to continue to improve? And we treated a degenerative meniscus.
Yes.
And it went about a year of seeing incremental improvements, and then realized, okay, I've plateaued, and came in and got another treatment. Right? So you can spread them out like that. You can do it every 2 to 3 months with platelets to keep building tissue back. It depends on how far it's gone, how well you respond. Sometimes, you know, some people aren't building enough tissue well enough, and we do one treatment, it's like, we didn't get anywhere with that treatment. 3 months and you're not any better. And you've got bone on bone and big bone spurs and bad range of motion, and maybe that's when we need to start thinking about a knee replacement, because those are successful, right? In most people.
In most.
I'm not a big advocate for them, because I think we don't try the things that really work before doing them.
Yes.
We do the things that break down the tissue more, and kind of predetermine that we're going to get a knee replacement in the future.
Eventually,
we break the tissue down more over time and then replace the knee. Whereas our system should fund building the tissue back before breaking it down, which is prolotherapy, PRP, before steroids.
Absolutely.
That's my philosophy, but right now the system doesn't favor that, and so it's an uphill battle to get people the treatment.
Yeah. So in this field of regenerative medicine, is there anything that you see coming up, anything innovative that maybe isn't available right now, but that you think down the line is going to be available?
Well, there's also the idea of, we say stem cells, but we argue about what that really means, and, right? So there are a lot of people, colleagues, that I don't do this invasive a treatment, but bone marrow aspiration. So you do use a larger needle to go into a bone and pull bone marrow out. And some people use it, just pull it out, inject it. I have colleagues in other countries that that's an inexpensive way to get some stem cells into the knee, right? In the US, it's more common to concentrate those stem cells. So spin them like the platelets and get more concentration, inject those. And there's very good evidence you can regenerate cartilage over time with that. For me, I haven't, just in my own practice for various reasons, I don't go that invasive, but most of the time I don't need to refer people to get that done. They get better with what I do. So, and then the same thing with fat. You can do fat aspiration, like a mini liposuction.
Okay. And
then you mechanically process the fat to get the fat cells out. And then there's regenerative cells in the connective tissue, and you inject that into an arthritic joint.
Okay.
So, and there's good evidence for these things. Obviously not enough to justify insurance paying for it right now. Although there are self-insured companies that are now funding it, who kind of make their own decision because they see it as a better option than just paying for the surgeries.
Certainly less
so
expensive.
We're in this transition time. In the future, the focus is going to be more on regeneration.
Yes.
And right now, the system is not built for that. What keeps hospitals open is the operating rooms. And so it's not a grand conspiracy, it's just the natural forces push people towards the more expensive solution that's kind of organized into the system and keeps everybody going, the whole system going. So again, it's complicated, right?
Yeah. Nuanced. Well, I appreciate your nuanced, non-surgical approach, and people that want to see you to explore these options, these regenerative medicine options. You're practicing here in Austin, Texas.
Yes.
And you're online at proloaustin.com.
That's me.
All right. Well, excellent. Well, thank you so much for joining us.
You bet. Thank you.
Really,
whoever's watching.
Yeah, really good information, and I'm happy it's getting out there.
Good. Thank you. I appreciate it.
Dr. Fullerton is a phenomenal provider of non-surgical treatments for your knees and other areas of your body as well. He practices in Austin, Texas, and can be found at proloaustin.com. And I'm Laurie Kurtz-Kelly of BetterKnees.com. I help clients here in Austin, Texas, and online worldwide. I offer customized plans to overcome knee pain regardless of whether or not you've had knee injections. I'll help you apply a very unique 3-part solution to improve your knees from the inside out. The sooner you get started, the more likely you can avoid a knee replacement and enjoy your active life for many years to come.